I'm really delighted to be chairing this webinar on the National Neonatal Audit Report on data from 2023. My name is Ngozi Edi-Osagie. I'm a neonatologist. I work in Manchester, but I'm also the National Clinical Director for Neonatal Care. And as usual, the report is really high quality, outlining really key metrics for neonatal care. I'd just like to say a big congratulations to Sam and the team for continuing to produce a report which is valuable for staff, for parents, and our babies as well as commissioners. It's a vital report that is really helpful in improving neonatal care. I really like the visual graphics that have been produced, as well as the access to a dashboard that has really good interactive tools. For those of you that have already accessed the report, you'll have noted that there are real improvements in nurse staffing, deferred cord clamping, and one metric I was really pleased to see was temperature admission. That has been a real nub for many years. This report has been going now the NNAP has been going for 17 years, and the improvements in care that have been attributed to neonatal care have been really astounding. The recommendations are really good as well, and there is that we should have more shared practice with networks, perhaps reviewing their own data and reaching out to areas that have consistently high performance. The other thing I'd like to mention to the team, and for those of you that are here, that these reports are really important. I was really fortunate to have a meeting on Monday with Baroness Merrin, who's the Parliamentary Under Secretary of State, and she had all the metrics for NNAP in front of her and asked me about them. So this report is really important. So over the next 1.5 hours, Sam is going to give us a summary of the data. We're really fortunate as well to have an example from an organisation, a provider, about improving optimisation. But I'd also ask you to put your questions and answers in the chat, because there will be an opportunity for Sam and the team to respond to questions that you may have. So without further ado, I will hand over to Sam, and thank you again for producing such a brilliant report.
Well, thank you very much, Ngozi, for coming and chairing our meeting, for which we're very grateful. I'm just in the process of trying to get my slightly laggy sharing system going, and then I'll try to. I'm hoping that you can all now see a full screen slide. Could somebody just affirm that for me?
Yes, I can see that, Sam.
Fantastic. That's great. Oh, unfortunately, I just somehow killed it. But that's great. So hopefully you can also see that the red border is there. So over the next little while, with a bit of a break, because I thought you might all get bored of me, Lynsey's going to talk about what they've been doing in Glasgow. I'm going to try and do a few things. I want to show you what the data for 2023 looks like for NNAP, and I'm going to point to some of the recommendations that we've made. I'm going to show you some new figure styles, some new sort of diagrams, which we hope are helpful. Hopefully you're going to end up at the end of this webinar thinking, oh, we should go and look at the extended analysis document. And there's a lot of stuff which is freely available online, which you can go and look at in the extended analysis document. I hope that you will all, perhaps already, but maybe in the future, we'll go and look at NNAP online, where the annual data is presented. And if you think that looks extremely similar to the old NNAP online, that's entirely not a coincidence. So it looks really similar, which is, as I say, intentional, but we've got a completely new version, and in the future that will allow us to iterate it better. I also hope that by talking, you'll have an idea of the utility of the dashboards, the so-called PAD and RAD, and ultimately the point of all of this is to facilitate local quality improvement and regional quality improvement. So the first thing I want to do is, unsurprisingly, I want to talk about outcomes, and here's a new figure. So all of these represent different regions in the audit, and I'm afraid we've left Scotland out of this. No, we haven't. The blue lines represent the mortality by years for the individual regions, and you can see that, for example, my own region, where hopefully you can see my mouse, mortality goes up and down a bit, as you might expect. the idea of this figure was it would give a bit of an idea of what the trend was over time. A big change that we've made in reporting mortality for this year is we're reporting in single-year cohorts rather than 3-year cohorts. We hope this was helpful. Clearly, we all want to be somewhere like Thames Valley and Wessex with consistently low mortality. Perhaps we want to be in a place like the Southwest where mortality seems to, on average, be going down. But the big picture is that overall mortality isn't really changing at all. And this is an apples to apples comparison. This is babies of less than 32 weeks, excluding the babies less than 24 weeks. And you can see that overall mortality is really unchanged over a period. Unsurprisingly, mortality is highest at low gestations, and I'll come back to the 22 and 23 weeks in a minute. But that's very important as we compare regions to make sure that it's not the gestational age mix of the babies in one region compared to another that might explain the differences in mortality. So we have these kind of what we call cat plots, caterpillar plots. And on the left-hand side of this panel, you can see mortality up the vertical axis. This is babies of less than 32 weeks. And overall, about 6% of babies die, which is this horizontal dashed line. And the dots in this cat plot represent different neonatal networks. I mentioned we might all perhaps want to be in the southwest of England. This is the raw mortality. But it's possible, it's plausible that the reason that other networks have higher mortality is because they have different kinds of babies. And so we do this so-called balancing analysis, whereby we take into account the different background characteristics of the babies, and we ask the question, what would the mortality of babies in a given network have been if those babies had been looked after somewhere else? And we do that by comparing a group, finding in effect a matched group of babies. So we look for similar babies elsewhere in the data set and compare the actual mortality in the network of interest to the whole of the population. And that way we get a so-called treatment effect. And this is in the right-hand plot here, a mortality treatment effect. So it appears that being looked after in the southwest is overall associated with a more than 2% reduction in mortality. The confidence intervals for that, this vertical line, actually cross 0. So you can argue that's not statistically significant. But we hope that this is a very helpful technique. And there's a lot of this matching analysis in NNAP. And I'll try to come back to some of that. So mortality, there's a bit of variation. If it appears there's less variation, it's because it's annual cohorts rather than 3-year cohorts. The least mature babies are very much of interest, and particularly everyone talks about the 22-weekers. We've shown previously that the number of admissions went up from 15 to 100 in 2022, from between 2018 and 2022. You can see that there's been a further slight rise in 2023, but nothing like the scale of a rise. So I suspect that the number of babies admitted is leveling off. And you can also see that the mortality is unchanged. So more overall survivors, but the numbers are still very small. So mortality is significantly lower than it appears, than appears to be described in the BAPM document. So we hope that this is helpful data too, and the BAPM document, as you may know, is being revised. So we made a recommendation, and it's one of the really fun things about the programme that we get to make recommendations. So we made a recommendation to NHS England. We thought that neonatal networks should be making plans for their populations, and the quality improvement activities should really focus on best practices. So if you like, potentially better practices from neonatal networks with lower mortality. And that comparative work is still going on. It's starting to go on between networks, and I think that's very valuable. We also made a recommendation, and we don't just make these up one person; these get made up by a very large committee in a very considered way. That the NIHR, National Institute for Health Research, should probably be trying to commission research to understand why it is that these mortality rates seem to vary, because there is more understanding to be gleaned here, I think. So that's mortality is an outcome. It varies by geography by a very striking, almost a doubling. So BPD, that's another outcome, and that's a bit depressing because, if anything, BPD is going up rather than down. It's certainly not going down. So the dark blue parts of each column here are death, which we always report alongside BPD, and the lighter blue is BPD itself, so oxygen dependency or breathing support at 36 weeks gestationally corrected age. You can see it ain't going down, not much missing data. That's the pink purpley bit. So here again, a new kind of plot. So gestational age, weeks along the horizontal axis. This is the proportion. The blue is the proportion of babies with BPD. And the red is the proportion of babies who die. And you can see that all the survivors at 22 weeks have BPD, a very high proportion at 23 weeks, and so on, decreasing. But even at 31 weeks gestation, there are some babies who are still in oxygen at 36 weeks. So we hope that this is helpful to people as they conceptualize what to do in response to their figures. So I mentioned this kind of cat plot before. There's really striking variation in the rates of BPD across neonatal networks. You can see here that there's a neonatal network with a BPD or death rate of under 35% and a network with a BPD or death rate of above 45%. And if we take into account the background characteristics of the babies, that still plays out. You can have a treatment. So being associated in one neonatal network is associated with a 5% reduction in rate of BPD or death, whereas in another neonatal network, it's associated with an increased rate of BPD or death. So, and that's by of more than 5%. So a very important difference in the rate to which we attribute this outcome. So we think that's still very important. It's not a new finding, but it's important. At center level, we see the same sort of thing. So same kind of plot. BPD or death on the in the left-hand panel here, BPD or death on the vertical axis, and each dot, each coloured or grey dot, is a neonatal unit, and the vertical line around those is the uncertainty around that. And you can see that, perhaps unsurprisingly, the units with the highest rates of BPD are usually those who are neonatal intensive care units, which are red in this figure. But when you take into account the background characteristics of the babies, we do a matching analysis, it becomes much more mixed. And there are neonatal intensive care units, the yellow ones are the ones who do surgery, that are associated with having a higher or a lower rate of BPD. And look at the scale on the vertical axis here for the treatment effect. It's really quite large. So being looked after in some neonatal units seems to be associated with almost a 20% actual increase in risk of BPD. Probably very varying practices. The fact that we could talk about why it is that the coloured dots are more on the right of that plot, but in effect, that's residual compounding, I think. So you might quite reasonably say, well, why is it that BPD rates vary so much? And of course, we don't know the answer to that. We do have a measure of an evidence-based practice, namely trying not to put the baby on the ventilator, which is what it says to do in NICE guidance. And this slide represents that, so it's a little bit blurry. My apologies, that's my fault, not anybody else's. The proportion of babies of less than 32 weeks who avoid being ventilated for the whole of the first week is about half, which I intrinsically find surprising. And you can see that the proportion of babies who avoid being put on a ventilator, ventilated with an ET tube during the first week varies enormously in crude rates on the vertical axis in the left-hand panel. And there are neonatal intensive care units where it's as low as 20%, and there are neonatal intensive care units where it's as high as 60–70%. And that is the matching analysis that we've done here, generating a treatment effect, takes into account only the gestation of the babies. So, but you can see that it really does appear that there are very different clinical styles. And so, again, we hope it's helpful to units to know where they rank in this caterpillar plot, and we thought that might be useful information to units. If you have a high rate of BPD, where are you on this plot? That might be a thing people would want to ask. NEC, this is a devastating outcome, very much in my world this week. We can see that there's not really an obvious change in rates of NEC in the big picture, a little bit of missing data. There are almost half the neonates in the country report not having a single baby with NEC, which is perhaps a bit surprising given that one of those is in NICU. The treatment effect analysis on an annual cohort doesn't suggest much difference, which is perhaps reassuring. The thing I would say about this is that the data completeness and in particular data quality is a work in progress. And a lot of work's gone into this at unit level, people carefully considering the quality of data that they're entering into Badger that we base the audit on. And so we're grateful for that ongoing data cleaning and assurance work. So nearly 9 out of 10 units wrote to us to say they were really confident in the data that they put in. And that's great. There's probably more work to do, both in the additional 1 out of 10 units, but also in terms of the quality of that assurance activity. The rate of NEC varies very much by gestation, and I hope, again, this figure will be of practical use to people. I think it's interesting that there isn't much difference between 22 and 23 weeks in the NEC rate, at least as we measure it. A steady drop-off, but it's not zero, even by 31 weeks gestation. So I think that's fascinating and hopefully of importance. So late onset bloodstream infection. So bloodstream infection, this is the proportion of babies of less than 32 weeks who experience 1 or more positive blood cultures with what you might regard, well, I would regard as a proper germ. So a so-called clearly pathogenic organism defined for us by a microbiologist. That is the growth of an organism whose growth alone would make you treat with antibiotics without the clinical context. So that cons is out, but E. coli is in, if you like. So between 8 and 9 out of 10 baby units told us that they'd entered every single positive blood culture into Badger. Thank you very much to those who did that. If you're a really optimistic person, then you could think that the rate of bloodstream infection was going down in aggregate a little bit. But you'd have to be quite optimistic because it does go up and down a little bit there, doesn't it? But I think this is really encouraging, and with the linkage work, which I keep promising, but will ultimately in the end happen, we'll have all those blood cultures automatically. Of course, the rate of bloodstream infection is strongly associated with gestation, but still not zero at 31 weeks. And a quarter of the 22-weekers get a BSI of this type. I'm impressed it's as low as a quarter, to be honest. So I think, again, we hope this is useful data. That's in the extended analysis report. And we've produced a balanced analysis, which I think probably does show an important increased absolute risk for a few neonatal units and a few with apparently a bit of a lower rate. You have to note the scaling of the vertical axis here. So an absolute increased risk of over 10% in some neonatal units and a reduction of around 5% in some neonatal units. So potentially that may be of interest. I'd be interested in your comments on that. So preterm brain injury is something which we are keen to measure, and we must remember, must we not, that Jeremy Hunt, the former health secretary, set out this ambition to reduce brain injury by half, and frankly, we're not doing very well at even knowing whether we're meeting his ambition or not, because there's an awful lot of missing data, never mind inaccurate data with regard to this. There are ODNs, there are networks where up to half the babies don't submit data for this, and that's a real concern. Having said that, 7 out of 10 units tell us that their data, they're absolutely confident in their data, so we thank them for that activity. I think we can't make much of these kinds of graphs. I don't think you can look at the graph and say our IVH rate is high or low from NNAP data at the moment. But I think there are still useful things that we can say from this data. Here we have gestation on the horizontal axis, and the blue part of the column is the babies who die. The red is the babies who survive, but with IVH 3-4, and the green parts is the proportion of babies who are both alive and have no IVH 3-4. And I hope this might be useful to a variety of users, and this is an extended analysis report. So cystic PBL, the apparently a lower rate of missing data for this, so that's kind of somewhat encouraging. Same sort of graph on the right here. apparently no 22 weekers at all with cystic PBL, so that's very good news. I think it's interesting how there's not quite such the same gestational age relationship with that. Overall, it's about one baby in 50 less than 32 weeks who gets cystic PBL, according to the data that we have, and that's it's about what we would expect, and actually the IVH34 rate is more or less what we would expect. Might be that probably is more worked on the accuracy of this data, as I was indicating. So here's a bit of a Venn diagram for those of you who are a little bit mathsy. Of the overall 8,000 babies, there are in total about 1,300 babies whose brain outcome data is completely undescribed. And then you can see within this red circle, there are a lot of babies who have IVH, 402 in total. And there's substantial overlap with the babies who have cystic PBL, or the 163 babies who have cystic PBL, about half of them also had IVH34. And what's really interesting to me is how high, or how apparently high, the rate of PHVD is post-hemorrhagic ventricular dilatation. So there's a case definition for that, which appears in the Badger system or on the NNAP measures guide. In order to have that, you have to have ventricular dilatation more than the 2 standard deviations on the Levine graph, but also prior IVH. I suspect this is over-recorded quite significantly. And again, our high rate of missing data. So I think there's more to do in terms of describing what's happened to the brain of this very vulnerable group of babies. And we need to be cautious about not over-interpreting this data. And I think that's really important. So we made some recommendations that the NHS England and the devolved governments should be making the neonatal networks review and address their rates of missing data for preterm brain injury and NEC actually, and use the restricted access dashboard to validate the data. And that the point of that is so that we can help neonatal networks and units to make quality improvement plans based on their baby's actual outcomes. So I think there's significantly more to do, particularly in the networks where very high rates of missing data. So I'm going to talk a little bit about optimal perinatal care, and I'm going to let Lynsey talk about optimal perinatal care in the real world. By optimal perinatal care, we're really talking about the sort of NeoSIP if you're in England, or the SP. Oh, I can't do the Scottish acronyms, but the SPSP, Scottish Patient Safety Programme. Or Peri-Prem Cymru, the sort of getting it right at the beginning measures, what some people used to call the BAPM-7. So optimal perinatal care, we have a composite measure. So this is the proportion of, but this is, as some of you will know from NNAP, the NNAP dashboard. And this graph here is the black dotted line is the national figure. And on the vertical axis is the proportion of babies who get all of the things that we measure, so antenatal steroids, magnesium, being born in the right place, deferred cord clamping, being admitted warm, and getting early breast milk within the first couple of days. So about less than one baby in 5 on average gets all of those things. The red bit, I think, is interesting, and it's different for different geographies. There's really quite a lot of missing data in the past, unsurprisingly, really quite low missing data now. I think importantly, we see a really strong improvement over the last few years. And in fact, I'm showing the Yorkshire network here. And those of you who haven't seen this kind of graph before may be aware of these pink triangles. That's because this is more recent data that the units within this network haven't had a chance to be really assured of just yet. But this is the NNAP dashboard. So optimization, and this is our composite measure. You have to have all of those in order to count them. So the components of that, being born in the right place, is one. And I know the center that the whole system is quite worried about this. If you're born in the proportion of babies that are born in a center of the most vulnerable babies born in a centre with an on-site NICU is really not changing year on year. It's about 8 out of 10. That's not really okay. So the black dashed line is an arbitrarily set target, if you like, and a developmental standard is what we like to call that. It's a little bit of an increase from last year, but not. It's not much of an increase, and we're actually nowhere near, not as good as 2020. So I think there's a lot of concern about this. And of course, networks that are changing to evolving to have fewer NICUs intrinsically makes the target harder to meet. Another aspect of optimization is antenatal steroids, and those of you who've been around for a while will remember that NNAP used to measure the proportion of babies who had ever met antenatal steroids in their in utero life, and that was significantly better than 9 out of 10, as you can see in the 2021 column here. But then we changed the measure and made it much harder to achieve. And I don't think we should interpret too much from these two lines on this graph, not least because it's important that we hit the point and whilst bearing the target in mind, rather than hitting the target and missing the point. But nonetheless, we think it's useful, and there's a little bit of variation, which I'm not going to go on about at enormous length. And so the magnesium sulfate, I think, a real success story for NNAP, but more importantly for UK neonatology. So the exposure was really very low, not so many years ago, and it's enormously better. The very inelegant change in the dashed line there is a change in developmental standard, which used to be 85%, is now 90%. In aggregate, more than 8 out of 10 babies are exposed to magnesium sulfate with very low missing data. So very encouraging. Not much change over time. I don't know whether this will change more. I suspect it might not. Whoops. And I thought I was going to show you that there's a bit of difference between neonatal networks, and it's not so much actually. But I think we've done brilliantly at improving the magnesium exposure, which, as I'm sure you all know, reduces the rate of cerebral palsy by dramatically, it appears. Deferred cord clamping is something that many of you will know I'm very passionate about, and I think it's remarkably easy to deliver, and the less complicated you make it, the more straightforward, the better improvement. Over time, as a neonatal community, huge changes in the proportion of babies who get a minute or more as deferred cord clamping. And the evidence certainly shows that a minute is appropriate, and it may be that more than a minute is appropriate. We simply don't know. Or we know with sufficient confidence. But an important change in the so an 8% increase on 2022 data, and you can see that on the dashboards that I've referred to as well. What I think is interesting about deferred cord clamping is how much variation there is between, in this case on the left, neonatal networks. If you're a preterm baby, less than 34 weeks, you really want to be born in the southwest, at least if you want your deferred cord clamping done properly. So very, very impressive. More than 3/4 of the babies there getting deferred cord clamping. But at centre level, there's enormous variation. And if you're a unit that's over here, what I think you need to be looking for is to find a friend who's over this side and compare and contrast your approaches to this. Is there other ways of doing this differently? So again, we hope this is really useful, and that's one of the unique selling points of an NNAP online. It's time I got off, I think. Normal temperature on admission, as Ngozi said, as a community, we've improved very significantly with respect to this. We made a recommendation to the departments of health that there should be a public awareness campaign, public and professional awareness of the nature and importance of signs and symptoms of preterm labour, because they're not the same as those of term labour. And then we've got something around quantitative fetal fibronectin. And we want you all to use the dashboard. So with that, I'm going to get off and let Lynsey talk, which means I have to find the right window and unshare, unless you want to overshare, Lynsey. So So I'd love to introduce Lynsey, still consultant neonatologist in Princess Royal Maternity. Have I got that right, Lynsey?
Yep.
Right. Fantastic. Well, thank you so much for being here. Tell us about your experience of improving perinatal optimization and team working in Glasgow. Thank you.
Thank you so much. Just checking you can see my slides and hear me okay?
We can see the
we can
slides and hear you.
Great, fabulous. Okay, so thank you so much for the invitation to speak today. I'm delighted to share some of the work. So I work in Glasgow, work across 2 intensive cares, and this work I'm going to talk about is the optimisation and the perinatal team building that we've been doing in the Princess Royal Maternity in Glasgow. So the PRM is a neonatal intensive care unit with a maternity unit in the East End of Glasgow. We've got approximately 5,500 deliveries per year. And this is a real snapshot of our optimisation journey, which has really been going on since 2019. So very much an overview, just given we've got a bit of restriction in time. So our optimisation journey began, as I said, back in 2019, and that was with the launch of the SPSP, which is the Scottish version of the sort of optimisation package, which was launched back in 2017. And when we looked at inwardly at our data, we knew that there was a huge variation in the various elements of the package, as shown there on the right. And we also appreciated the real challenges where optimisation has sat within the Neonatal Audit Programme, but many of them are obstetric interventions. And that has been really challenging in creating huge barriers in terms of who owns the data, how do we interpret it, and how do we feed it back across our teams. So we came together as a multidisciplinary perinatal collaborative group and really wanted to look at ways in which we could improve optimisation through standardising the way we manage these babies, the way we work and work collaboratively, and also enhancing the knowledge and awareness, because that was clearly a real deficit when it came to the interventions. So the first part of this phase of this project was introduction of their preterm bundle, which was multifaceted and looked at different aspects of the team working and how we could really come together. And it had 3 phases. It had the preparation phase where the teams would come together, allocate our roles, clarify a really strategic, well thought out delivery plan, making sure the environment was optimised, the equipment was optimised, and everyone was very prepared. We then introduced a preterm pause, which we've been doing for several years now, and this has been really important to highlight the importance of the interventions and just summarising them at delivery, and then looking at this, clarifying the shared goals at delivery, which include deferred cord clamping. And then afterwards, it was just that introduction of a very delivery family-centred care with a delivery room cuddle and evidence-based approaches thereafter. So this was important in making sure we had that very standardised and consistent approach. But we fully appreciated that we couldn't just introduce a bundle without really supporting it with a really robust package of education. And back in 2019, this package here, introduced by the SPSP team, was a lovely infographic, but people were a wee bit unsure as to what it meant and why we were doing it. So we developed an educational poster, which was created as a really highly visual poster, but we wanted to make sure that we were creating that sort of visual reminder that was readily available across all maternity units of evidence and the life-saving benefits to all of these interventions. This has been a really successful poster that was shared throughout Scotland, and I'm hoping beyond, and hopefully many of you on the call will have seen it today. And as I said, it should be in every unit within Scotland, and this has been very, very useful in maintaining that awareness. In addition to the poster, we've undertaken a lot of teaching, and it is very clear that optimisation can't just sit as a one-off teaching. Optimisation has to be very, very consistently led and taught, and that is for all junior doctor inductions. So we have undertaken a huge amount of teaching. So every junior doctor, neonatal and obstetric, when they join the organisation, get standardised optimisation teaching where they can all very much recognise their role and the importance of this work. We also teach the neonatal nursing students that have just joined, and we also undertake teaching within the midwifery cohort as well. Not just twice yearly or 3 times a year, we undertake lots of bite-sized and really opportunistic teaching, and this has really led to the optimisation language and terminology being very embedded in our day-to-day practice, and that has been a key to the success of the work as well. So just like Sam, I'm a very much DCC convert and very, very passionate about it. And this has led to a huge amount of work within the Glasgow area to try and completely revamp the misunderstanding behind DCC. When we did a deep dive as to why our babies weren't getting it, there was a lot of just failure to understand the basic physiology and we've had so much evidence out there to support it, so we needed to do a full reframe and do lots of work on this. So we've done a huge amount of work and completely rewritten a guideline, which has led to a lot of light bulb moments for a lot of people and has really changed the mindset behind DCC. We've created infographics to try and make, again, that highly visual reminder with a lovely, consistent colouring template messaging for the teams to be aware of. Another success has been introduction of a life start trolley, which is where we scrub in, we stand side by side with our obstetric colleagues to make sure that as many babies get DCC as possible, and DCC is the absolute norm where we work. This is the early data, not NNAP, but this was our early local SPSP data, which showed a massive increase in our DCC rates, which was very satisfying to see. And what we've also seen with that is a reduction in things like blood transfusions, need for inotropes in the early stages as well. So it really has been hugely beneficial for our babies. Moving on now to a whistle stop through our improvement in maternal breast milk. And again, this has been a hugely successful piece of work particularly within the past year within Glasgow. And this is following on from a project called Express Yourself, which was again introduced as part of the optimisation work, which was really targeted on improving the amount of babies that were exposed to early breast milk. Within the Princess Royal, we've had an increase in resources of our infant feeding team, and we've now got our fantastic 7-day-a-week service with an unbelievably driven, dedicated, passionate team who are blink and you're there. They counsel the women antenatally as soon as we've been in to speak to them. They're there with their lovely purple boxes, which were introduced by our charity kindly as part of this work. We've got resources, we've got kits, we've got education, and the real consistent link between labour ward, postnatal ward and the NICUs of this team of people has been an absolute game changer, because these mums are fully supported and their volumes are, as maximum as peak as we can, because we've got them on expressing within 2 hours of birth, and this has been hugely beneficial to have this amazing team on board as well. And this is just the data to demonstrate this from our lovely new dashboards, which we've just got access to, and this shows the difference that this work has made in the past year. And I can't not mention the real move towards a real perinatal team working culture that we've seen in Glasgow. And many of us have known the way we've used to work. We've traditionally worked in a very silo working pattern. We've trained separately. The colleges are separate. We have very different responsibilities and roles. And we've led into real silo working pattern. And if you read, obviously, the Kirkup and Ockenden reports, you see that the silo way of working has hampered communication, team working, and ultimately can impact outcomes. So we very much moved to a very different way of working where it's much more collaborative, and where the 3 core specialties of midwifery, obs and neonatology work very, very closely with that extended perinatal team, with our nursing staff, our anaesthetic colleagues, our AHPs, with women, babies and families at the absolute heart of how we work. And the way in which we approach preterm birth in the Royal is a very collaborative approach. So in the early stages, when women are admitted or they're on labour ward, we have a very, very joined up way of decision making and planning for these women and these families. So in that regards to optimisation, whether we need to transfer, and it's very much weighed up and balancing both maternal and baby interests. We also are very keen to undertake a joint counselling approach, so particularly with the extreme preterm babies where things are looking a little bit more uncertain. We want to make sure that both neonatal and obstetric teams are very much counselling these families together and having early conversations about milk. The preterm pause, as I mentioned earlier, has been a real game changer, where we actually have a pause and a formal moment for the neonatal team after the obstetric theatre pause or before a vaginal delivery. We'll make it very, very clear of the communication and the plan for mum and baby, and making sure that everyone in that room has that shared goal of at least 60 seconds of deferred cord clamping, making sure that baby is warm, transitions gently, and gets a cuddle with their mum after birth. And then thereafter, making sure that it's a really strong evidence-based approach, supporting the mums after birth for expressing, and having a joined up approach to keeping families updated and supported. The culture has shifted massively over the past few years, and I think it's very clear to say that the communication is far improved. We've really focused on building on a really enhanced positive working relationships, and that's across all tiers and specialties within our maternity building. And that has really helped to create a really positive, supportive and open culture with psychological safety. Perinatal leadership has been key, and having a named obstetric and neonatal leads with champions on the floor really consistently bringing home that message of how important these things are every single day has also been very important. And let's not forget the education. So in addition to the induction sessions, we also have undertaken lots of perinatal case-based discussions where there's ongoing education, particularly trainee-driven as well, so that they can kind of get on board if there was missed opportunities, or we can learn from excellence as well. And that allows us to build that culture of continuous learning and improvement. We've developed various ways in which we can sell our story and share the data, because this is a huge part of the challenge, is that we're data rich but knowledge poor at times, and we don't know how to share the data, and some run charts don't talk too much, and it's great to see that the dashboards give us more detailed insight into it, but then not a lot of people can understand run charts. So looking at this really visual story has been helpful for our teams to see what's happening with our data. And this has been shared through all of the specialties within the unit. And ultimately, what the difference has this made? So magnesium sulfate is the norm now. We have really transformed the way, and this doesn't go back quite as far, but our magnesium sulfate rates were around 60%, and generally this is sitting between 95 and 100% of babies. Deferred cord clamping, again, this is taking into account all babies, and the previous data was including some exclusions like monochoric twins and twin-to-twin, but this has again shown that a really consistent approach and a gradual increase in DCC has been successful. And ultimately, bringing all of this together, this has led to the Royal being one of the most highest performing units in the UK with regards to optimisation. And although we're sitting, just over 40% there, we've still got a way to go, because obviously every baby, every time should be getting exposed to these interventions. So still lots more work to do. So our final messages, key learning from the work that we've done. Education is absolutely critical, and every single member of our perinatal teams must be aware of the life-saving benefits of every optimisation element. You won't change your behaviour unless you have evidence to support why you need to change it, and this is what we've been doing in the Royal. Consistency is also key, so embedding that really standardised approach so everyone knows what's happening with every preterm birth. It's the same time for the same baby every single time. And if we don't achieve optimisation, we have to be inwardly looking at ourselves and our teams and our decisions and our processes to understand why babies don't get exposed to these interventions. Perinatal collaboration and perinatal leadership, again, are with having that dedicated, really passionate team with persistent, visible leadership is really key in maintaining that ethos and momentum of this work. This work needs to continue for the long term until we embed it and get better at it. And the collaborative approach is obviously critical for improving optimisation. So I'm encouraging you now to please build your teams if you haven't already done it, break down any silo working patterns to try and foster that really collaborative perinatal culture with the highest quality team working and united in pursuit of shared goals, so that ultimately we can give every mother, baby and family the best chance of a good outcome. Thank you.
Thank you so much, Lynsey. I'm guessing that it will be fair, lots of applauding hands going up. Very impressive presentation. Lynsey's put her email address on a slide, and I think she'd probably put it in the chat as well. I'm guessing she might be prepared to share some of those resources, maybe even some of her slides if you're really nice to her. So thank you very much indeed for that. I'm hoping you'll be able to hang around to do some questions potentially, Lynsey.
Yep.
Thank you very much. I'm going to plug on remorselessly, if that's okay, people, just to give you a bit of a flavour of what's available in our resources, and then we really do want to do some questions. So I'll get on if that's okay. So many of you will know that we try to break down our measures into parental partnership and care. I'm not going to cover every measure today, but this is exciting. I'm not moving on, which is not quite what I was hoping. There we go. So our first partnership measure is all about breast milk. And I thought it was quite important to think about what good really looks like for breast milk feeding. I think it's about high breast milk availability, but it's also about breast milk use. So you want to both be able to have the breast milk there, but also actually use it. And then continue to be able to use breast milk through the admission and hopefully discharge our patients home on at least some breast milk, and preferably exclusive breast milk feeding and maternal milk feeding. And the graphs, which I'm not going to spend any time talking about, are designed to show how that varies. So we've got a number of breast milk measures, as many of you will know, thank you, Liz has already shown you the NNAP dashboards, but I want to advertise the utility of these to you. So this is the restricted access dashboard, and this is only anyone can get access to this, but they need an email to be copied in an email from their local NNAP lead to the NNAP email address, and we'll put you on. I'm going to refresh that twice a week for the next month, and then go down to doing that, refreshing those memberships once a week. So I'm hoping that, as you can see, the national average is the black dashed line, the middle 50% is the grey, and the middle 3/4 is the lighter grey. So it's designed to give and there's gestational age breakdowns at the bottom. Big picture, 2/3, 62% of babies got early breast milk on the first or second calendar days, and that's okay. Astonishing level of variation between centres, though. So there's networks on the left-hand side and centres on the right. This is just raw data, so you can see there are neonatal intensive care units off on the right here, where more than 9 out of 10 babies got some breast milk on the first day of life, and there are neonatal intensive care units where that's less than 1/3. So that might be about breast milk availability, or it might be about the willingness of clinicians to use breast milk, but that's a really important difference. It is worth saying that we changed the measure just in a minor way during 2023. Hopefully will correct me later, but that doesn't explain. And that was because so-called milkless mouth care, when there's not enough breast milk to put down the nasogastric tube and people just put it in the mouth instead. We started including that. I think in late 2022, I forget the exact date. That's not the whole explanation. There's clearly an actual change in breast milk that's going on over time, which is really encouraging. And breast milk feeding at day 14, there's much less variation. So overall, about 8 out of 10 babies get at least some maternal breast milk on day 14. But at discharge, over time, on average, it's a bit depressing. About 6 out of 10 babies go home getting some maternal breast milk, and that really hasn't changed very much. If you're a really optimistic person, you'd say it changed 3% in 11 years. I think you have to be quite an optimistic person to think that, to be honest. What I want to show you, though, is that varies quite a bit by centre, and some centres are in places where breast milk feeding is more. So where I was born and bred, breast milk feeding is more of a thing than it was where I did my medical training. Not many people in the Northeast breastfeed their term babies, never mind their preterm babies. So partly it's about cultural milieu, but there's probably an important influence of practice on that, and the variation you see in raw, any breast milk feeding at discharge rates. You can see your own centre on this on NNAP online. The figure on the right is exclusive mother's milk feeding. And that's very different. You'll see these figures in the extended analysis report, but exclusive mother's own milk feeding, much lower aggregate rate. So instead of it being around 6 out of 10, it's less than 2 out of 10. And lots and lots of variation. Some units have almost nobody going home exclusively breastfeeding. This is babies of less than 34 weeks. So I hope this is of real interest to you. I want to show you some scatter plots. There are some lines which appear to show that there are correlations here, but these correlations are so weak that you should not assume that the line means anything at all. There are this is breast milk feeding at discharge, any maternal breast milk at discharge on the horizontal axis, and I hope you can be convinced there's really no relationship. Each dot is a unit. There's really no relationship with how much the proportion of babies that are fed breast milk on the second day of life, by the second day of life. So there's not much a demonstrated association between units in that regard. And equally, there's no real relationship between the rates of exclusive breast milk feeding at discharge on the vertical axis and any breast milk on the horizontal axis by units. So there are units that have got very high use of some breast milk, but very low rates of exclusive breastfeeding. And equally, there are units that have got very high rates of any breast milk, with reasonably high rates of exclusive breaks for but still overall, in aggregate, we're all quite unsuccessful at sending babies home on exclusive breast milk feeding, and that is a real concern and of real interest, I think. Parental consultation, speaking to the parents within 24 hours of the baby being admitted, that's a very low bar. We manage it in about 19 out of 20 babies. I'm slightly worried that this might be a little bit worse over time than it has been, but in general, we're doing, and there's some neonatal variation, but I'm not going to go on about that. Neonatal nurse staffing. So this is a big story because there's clear evidence that we don't have enough nurses, and big news there is an improvement, and that's due to the at least in England, due to the injection of government money. I've temporarily forgotten the acronym, and my apologies, Ngozi. But the critical care, I've forgotten the name of the thing, but there's more money around for nurses, and that's reflected in the staffing in 2023, and that seems like a really good thing we should celebrate. So this is the proportion of babies, a proportion of shifts that are staffed according to the recommendations. There's a huge variation between neonatal units. Each dot in this figure is a unit. The horizontal axis is how big the unit is. It's a measure of activity, and the vertical axis is the proportion of units that are staffed according to the recommendations. And if you just concentrate on the pink dots for a minute, or are they red, pink? The pink dots, each one is a neonatal unit, and you can see that there are units of mid-size, about 10,000, who have very poor staffing and have very good staffing. And that's even true amongst the LNUs. There are ones with very good and very poor staffing. In general, the smaller the unit, it appears that the better the staffing is. That's slightly a structural feature of the measure, but lots of variation between units. And so it's really important that the networks chase down and make sure that funding is being delivered, which I know is going on. I'm going to finish with some care processes, and there's more good news here. On-time screening for retinopathy of prematurity, new guidance in 2022, published in March 2022, and it felt really quite challenging that people would be able to do the on-time screening, as in the correct week. So new guidance was published at this point, or there's actually a brief period we don't measure, but there's an 9, nearly 10% increase in the on-time screening proportion. So difficult target. Recently recently agreed, and an important change. Very few babies get no ROP screen. Some get a bit early, some get a bit late, but a significant improvement in adherence to guideline, which I think is very encouraging. Lots of variation between units. There are units which do very well at this, and units that don't do so well at all. And similarly, it's of great interest to me, there are networks where this goes well and doesn't go so well at all. It's a RCPCH, RCOG, RCPCH, RCOP guideline, and some of you will know it's just about to be refreshed slightly. And the calculator, it will be reissued as part of that. Follow up at 2 years. As a community, I see steady improvement. I'm not a patient guy. I'd like that to be better. The standard we're aiming at, or that we're measuring here, is really very low, and only 3/4 of the babies are getting followed up at 2 years. This is babies less than 30 weeks. So what do I think you should do? I think that all networks, or units and networks, should know their results, and you can use a variety of tools to do that, depending on the purpose that you want to know your results for. But you should know if you're a high BPD unit or a low BPD unit, and you should know if you're in a high mortality network or not. And an NNAP online may be helpful for that, and the PAD and the RAD might be helpful for that, and the public access dashboard, restricted access dashboard. The spine plots might be a helpful way to, I'll come back to those in a second, I'll show you. The posters, we hope you will be displaying posters in your neonatal units. These are intended to be parent facing, but will also have a staff information function, as Leslie's shown us. Informing people and using accessible language, really important. There's something about improving the way that we measure some of these outcomes I'm thinking particularly of NEC and brain injury, and the RAD in particular is a really helpful way to review data, and we will again be running an assurance window early 2025. And then, of course, having understood what you're good at and what your challenges are, then we want you to make, and I think you probably all already are making, quality improvement plans according to what your local, regional, and potentially national priorities are. So these spine plots are a way of summarising on the left Bradford and on the right Yorkshire and Humber's results for a whole bunch of different measures on a single sheet of paper. So if you only get a chance to show one slide to your trust exec, this is a way of representing a unit's result. It's quite reductive. The vertical dashed line is the national average. The pale blue is really the expected range, and the dot is where the unit, or on the right hand side, the network features compared to the national range, and the horizontal line is the full range of normality. On the right hand side is good, on the left hand side is bad, and you can see Yorkshire's got a bit of a mortality challenge, etc. All of this stuff is up in the public domain, so there's no discomfort about showing it. I'm going to get off and see whether we've got some questions. I saw one from Janet in the chat, but I know you'll, or I hope you'll all be typing questions in, and we're really happy to try and take some and answer them if that's helpful. If you haven't already gone. Should we start with Janet's? Oh, go on.
Yeah, Lynsey as well. And I think there are quite a lot of questions.
Great.
Lynsey, there are lots of questions for you as well, but we can start with Janet. You can see the questions as well, Sam, can't you? So composite measure, have you got assurance that this is correct in NNAP?
Yeah, we're pretty confident that it's correct. In NNAP, we do occasionally make minor mistakes, and we're really grateful to users who point stuff out to us, and we really relish the conversation with users, because there are sometimes things that users can see that we can't see. But what Janet's describing about what she sees in Badger is not what we present in the RAD. So I've actually forgotten, Janet, who your NNAP lead is in Newcastle, but your NNAP lead can give you access to the RAD, and actually, if you write to me, I could give you access to the RAD, because I definitely know who you are. And we could, you can then see how the composite is built up. That's probably the easiest way to see that. I hope that answers the question.
Okay, there's another question. There are two questions here about admission temperature. For babies admitted several hours after birth, example from the postnatal ward, the admission temperature is captured from birth on the dashboard, making it look as if admission temperature didn't happen on admission, which sorts of skews the data. I suppose it's a comment rather than a question, but any comments with that, Sam?
Yeah, so when the English MAT NeoSIP programme was introduced, we agreed to expand the eligible group for the temperature measure from less than 32 weeks to less than 34 weeks. And you take these decisions and then you live with them. There aren't babies at 33 weeks who go to the postnatal ward, and babies sometimes go directly to transitional care, although that does seem to be very unusual now at 33 weeks gestation. So the standard, and this actually fits with what BAPM say in their moderate preterm guidance, is that babies of less than 34 weeks should go to a neonatal unit initially, and they should go early. And then they can then go back out into a transitional care unit or wherever. So the standard that we're measuring against is having an admission temperature done at less than an hour of age and it being in the normal range. And the denominator is all the babies admitted. So the 38-week baby who goes to the postnatal ward and isn't inside the measure. So we think that pretty much it's pretty fair, we hope, but happy to correspond with you by email. I'll put my email in the chat.
There's another question here about QIS staffing numbers. They're not included, and so someone's asking whether you can include nurse staffing, QIS staffing numbers.
I'd absolutely love to. We used to do that. and I don't have an NNA or a nursing colleague on the call, as far as I'm aware. But the bottom line, when our QIS measure was felt, which we did run for a few years, was felt to be unfair, and the sort of bigger picture stuff, and you're closer to this than I am, Ngozi, but I'm not sure everyone quite agrees what counts as QIS. I was aware that there is a phenomenon in this measurement thing of what we call gaming, that people put the data in so that they can try and hit the target, and in so doing miss the point. And I'm aware that people who didn't have what we thought was QIS were being ticked off as QIS. So the standard was 405, but of course 405 stopped existing really quite some time ago. So I'd love that to be the case, but it doesn't currently seem to be practical. But if you've got a practical suggestion that everyone would be able to more or less agree with, then I'd love to move that forward. Write to me.
Great, Sam. IVH missing data, is that percentage available in the NNAP online report? So someone's tried to find it and couldn't find it. But that is available, isn't it?
I believe so. I think it's in the tables in NNAP online, but you might be looking. We've had a web link challenge, which will be sorted today or tomorrow. If you want to look at the 2023 NNAP online data, then if you go to the college website and go to the NNAP pages on the college website, I can't get direct to it from Google myself. Go to the NNAP pages on the college website and follow the links to NNAP online from the NNAP section of the college website. You'll find, and I think the missing data is there. And certainly the national data is in the report, and it's in the extended analysis report. But if you want to find out what we think yours is, and the other way of doing that is to look at the RAD, the restricted access dashboard. And if you'd like access to that, as I say, write to us, but your NNAP lead needs to be in that conversation so they can sort of approve of you, if you like.
You show some spine plots at the end of Bradford and Yorkshire and Humber, and someone's saying they can't find them on the dashboards. Where is it that you can find those spine plots?
Thank you. I appreciate that the outputs that we put out, there's quite a lot of them, and it may not be that's transparent. So thanks very much for asking the question. The spine plots are on NNAP online. So I haven't really got time to do this justice, but there is still, at least inside my head, a rationale for there being NNAP online. That's data for assurance, as in I know that such and such is a good place because their NNAP results look like this, and data for improvement, which is those graphs that Lynsey and also I showed, where in the ones I showed was 2017 through to 2024, so quite long time periods. You can actually play with those dashboards. So there's a publicly accessible dashboard. So they've got different purposes. The spine plots are not available on the dashboards. The spine plots are available on NNAP online. And they are there because that's where I've gone from.
Yeah, they're there. Is it possible to show data on denominators within the different units?
It depends. So one of the broad, a little bit hard to know what the question is asking about, but the broad challenge that we have to be mindful of in making stuff publicly accessible is not to deductively disclose the identity of a baby. And so I'm not entirely sure I fully understand the question. The denominators are, I think, for most things available on an NNAP online, which is publicly accessible. Okay. Sorry if I'm being thick.
No, that's fine. I think they can clarify if there's more they want to know on that question. There's one about 2-year follow-up, and this is one I know bugs me quite a lot as well. When you have babies who are eligible but move out of the area or move abroad,
yeah,
how do you exclude them? Well, we don't actually, do we?
No, we don't let people just discard the babies that they find hard to follow.
Discard's a new word.
Yeah, it is a harsh word. I know. I was intended to be a joke. All services have this. So we all services have families who are, I was just about to say, move to Georgia or France or something, and that they become impossible to follow. All services have that. And much more commonly, and particularly in some geographies, but actually in all geographies, patients who move to another area. And in that situation, we still attribute, so Bradford born and managed baby who we discharged from Bradford is attributed to Bradford for follow-up. And will continue to be until we find a better way of managing the attribution. We haven't found a way of what I'm very reluctant to do is to have a system where Bradford could say, oh, I don't want to follow that patient up. We'll say it's somebody else's job without somebody else agreeing that they accept responsibility for doing the follow-up. So we have had lots of conversations about this over the years. And I think it's possible that a trading arrangement could be set up whereby Bradford say, look, this patient now lives in Leeds, and get their colleagues in Leeds to sort of take it on within the system. It's quite it's a little bit hard for me to see how that will actually happen at the moment, but I'm not by no means against that. But then it needs to be reciprocal. Someone needs to accept responsibility for it. Otherwise, there will end up being gaming.
Yeah, and I think that's one of the things you really want to avoid. There's a really good question here about mortality linked to activity or nurse staffing. Could you do that?
So when I look at the data, and particularly this time of year, if I'm honest, I think, God, there's so many things you could do. And of course, some of that work's already been done. So there is reasonable evidence that mortality is worse when there's worse nurse staffing. And I'm particularly interested in activity too. So in principle, we could do that. In practice, we probably need to do that with partners rather than just on our own. And we are doing that sort of work with partners, not those things in particular. But if you've got an interest in doing that and the right sort of academic backup, then by all means get in touch. I think it's really important that we continue to ask those questions. The centralising the little babies, that's a done deal, I think, and I don't think anyone's going to argue with that. But the question, the size of any effect of nurse staffing on mortality would be pretty important, I think.
Yeah, it would be important to know. There's a question here about EPRs, electronic patient records, and whether you're aware of whether this has had any impact on the submission of data completeness.
Yeah, absolutely. We're absolutely aware that of how very challenging it is for colleagues to manage some of this stuff. So I would point to the examples of things where this is going well and the extraordinary commitment that people show because people value getting the data in. So not long ago, I had a meeting with colleagues, I probably shouldn't, who were really upset that something wasn't showing very well for them. But I learned about how carefully they clean their data and the effort to which they go using both an interface between their EPR system and some human oversight of the data to make sure that they're really accurately describing what's going on. And as it turned out, something relatively minor and easily fixable had gone wrong in a tiny part of that. But I think that's a great example of people valuing the data flow and doing the right thing. There are people who are less committed to that, if I'm completely honest. And the principle that BAPM, who I'm also part of, are committed to is trying to put the data in once and not having to do double data entry. And so I think, well, that makes perfect sense to everybody, but we don't live in a perfect world at the moment, and actually probably particularly not at the minute. I know that Ngozi and others are working to try to improve this, and I can quite easily put my blue sky thinking hat on and describe how I think it ought to be. And I think actually ultimately will be, but I've sort of been saying that for 3 or more years, well, more than years, 4 years at least. So I'm reluctant to get too much into that, but I think a solution will in the end come. For now, I hope you value the data. One of the things that I think Humphrey's done brilliantly with the RAD, the Restricted Access Dashboard, is linking the product that you see, the time series graphs that Lynsey and I showed, for example, with the underlying data, which if you can get in the RAD, you'll see the individual babies as we see it. And so I hope that's helpful. I certainly hope so.
We've got a couple of minutes left, and Chair's prerogative. There's a question here about mortality and poverty, which actually links to deprivation. So it might be useful to just say something about the work that you might be planning to do on linking some of your outcome measures and some of the measures that you do with other aspects of things that might be interesting.
Sure. Well, thanks, Ngozi. I think Ngozi knows a little bit about what we're aiming to do. So, we're really concerned, as I think Ngozi also is the executive of the Race and Health Observatory. I forgot what it's called, but how the structure is organised. But we're concerned to make sure that perinatal optimisation is delivered equitably by ethnicity, but also by deprivation. And so we've got an ongoing project on that. Quite a lot of work has been done. The results are quite interesting. In some aspects predictable, and in some aspects not predictable. There's some good news, and there's also stuff that we can do. I can't really say more than that at this point, but we do aim to be able to show either that we're already delivering an equitable service, or pathways towards delivering a still more equitable service. Whatever, the effect sizes are relatively small and won't explain all of the health disadvantage that deprived and I think minority groups undoubtedly experience. But anything that we can do as perinatal teams to improve that is clearly welcome. And if there is stuff, so I hope to be coming out to people with results of that analysis quite soon, and we'll try to get it in press as soon as we can.
Thank you. So thank you so much for the excellent presentations. Lynsey, the work you have presented is fantastic, and I hope that you have people contacting you, because I think you have shown what can be done with the right leadership and culture in a unit, where you can just achieve quite a lot. For those of you that we haven't got round to your questions, I think the team still have access to the questions, and will hopefully be able to provide a bit of a summary of where you can find things. There are lots of questions of where to find spine plots and things. And so hopefully when we have a sort of frequently asked questions at the end of this, that will be helpful. But thank you all for attending. I've really enjoyed the afternoon as well. And it's, as usual, really brilliant. Thank you.